Welcome back, everyone. We will proceed to our next session, and I welcome Dr. Sukesh Chandran to moderate the next talk titled Equitable Care for Sickle Cell Disease in Chhattisgarh by Dr. Yogeshwar Kalkonde.
It is my honor and pleasure to introduce Dr. Yogeshwar Kalkonde, a neurologist by qualification. He's involved deeply with public health, research, and advocacy due to his deep interest in health of rural and Adivasi people. Though having developed competency in both training and experience wise in India and US in the area of basic sciences and clinical neurology, he left US where he was faculty at Baylor School of Medicine, Texas, seeking higher challenges, which basically was working with Adivasis in central India that had limited access to care, which he has been doing for the last 12 years. And of course, trying to find grassroots level solutions for chronic non-communicable disease and other health problems. Though based out of with the Sangwari group at Ambikapur in the Sarguj district of Chhattisgarh since July 2021, he was with Search at Gadchiroli for 10 years before that. Sickle cell disease is a significant non-communicable disease in this area, and we are hoping to hear what and eagerly looking forward to hear what he has achieved with the Adivasi people in the area and what care has been proposed for patients with sickle cell disease. Having got a gold medal in pathology during his MBBS days at Nagpur, obviously I can understand his interest in sickle cell disease and in other than neurological deficits. Dr. Yogeshwar.
Thank you so much for that kind introduction. And I would like to thank the organizers for this kind invitation. It's a humbling experience to be here at this Center of Excellence in Service, Research, and Knowledge. And it's also a quite liberating experience for youngsters here to be in public health. You can pretty much take any area of work and you can work for the rest of your life. So although I'm a neurologist by training, it doesn't restrict me to work on people's health problems. So why equity? I mean, it was fantastic that Dr. Anand Zakaria sort of had this theme as equity, and I was wondering why we need to discuss equity in the medical education. In 2016, I went for a conference of American Academy of Neurology in Boston, and at the end of that meeting, they were discussing what are the crises in medical practice. And the CEO of AN is discussing the crisis in medical practice was loss of meaning in medicine. Now, there is a field which automatically gives meaning to your life. Now we are in a crisis that medicine doesn't give you a meaning. You are directionless, you are frustrated. And so why that happens? And I think that the reason that happens is because, what has been very sort of aptly captured by this movie in 1936 called Modern Times, right? So Modern Times is a Charlie Chaplin movie. Those who have not seen it, please see it. And what is happening is there is what I call conveyor beltization of medicine. So we have become like a technicians, super technicians, doing more and more work and doing repetitive work and losing the perspective, the larger perspective of social medicine. And there is huge need to inject that social medicine perspective into medical training. And I'm going to share my learnings and one such experience where don't restrict yourself to sort of one area of care. So we'll start with a clinical case. So Sanyaro, I'm changed the name, is a 40-year-old lady who came to clinic with left hip and leg pain for about 4 years. And she has been taking pain medicines locally from informal providers. And, they're called Jhola Chhap doctors, although in India, they are the largest number of providers, whether you like it or not. So she came with her husband on a motorcycle from Ranpur, which is about 15 kilometers from Ambikapur. I always, my friend Abhijit, who's here, we always ask how patient came to the healthcare facility because it tells you a lot about, their challenges of seeking care in a medical facility. Her pain is gradually worsening and she now has pain while sweeping floors, sitting cross-legged and squatting, which interferes with her daily activities. And she also feels tired easily, denies any shortness of breath or chest pain. And past medical history was significant that during her second delivery, she had a lot of pain that she described and she needed 2 units of blood. She was not asked to take any specific medicines after that delivery. And during her third delivery, she felt very weak and again was given 1 unit of blood. Past surgical history, there was none. Family history, she has 3 children. There's a daughter who's 21 years old and married, 18 and 8-year-old sons. And children are in reasonably good health. They deny any family members getting diagnosed with any major ailment. And she was not, when she was seen first, she was not on any medications. And OBGYN, she has regular menses and she's G3P3L3. Social history, she lives with her husband and 2 children, and she has a pakka house and 1.5 acres of farmland. So the examination showed a lady weighs 36 kilos, and Yogesh Jain is here, so I need to mention her BMI. And the BMI is 17.1. And again, as I said, I mean, adult malnutrition, you can clearly see that there. And rest of the clinical examination was insignificant except moderate pallor, mild icterus. Liver spleen was not palpable. And she had some difficulty with internal and external rotation of left hip, which was painful and restricted. And it was free on right side. So this is a very simple test to, I do this in all my sickle cell patients. Just internal and external rotation of hip will tell you how the hip is doing. Otherwise, if you don't ask, patient may not complain of hip pain as such. Labs, hemoglobin of 7.5, MCV 73. Rest of the labs were unremarkable except bilirubin of 3.2, indirect being 2.4. Liver enzymes were okay and urea and creatinine were okay. And this was her X-ray of both hips, and we can see here that her left hip joint at the head, the ball of the femur head is it's damaged. And if you see more carefully, you will see some blotchiness on the right head of femur as well. And we got her MRI subsequently, which shows involvement of both hips. And then during this interaction, this was in month of August in 23, she finally gets a sickle cell card. Because she had solubility test, this was positive, and then she subsequently underwent electrophoresis test, which was positive. So at the age of 40, she is finally told that you have sickle cell disease. And the usual closure, and I'm using this word usual a little sarcastically, that the way we usually as clinicians, busy clinicians, how do we close a case? So patient is diagnosed with sickle cell anemia and avascular necrosis of head of left femur, and as I said, subsequent MRI showed actually bilateral involvement. And she was provided with sickle cell card at the age of 40, and she lives only for 15 kilometers from the divisional headquarters, which is Ambikapur. And she was started on hydroxyurea for the first time in her life, and she was given paracetamol and amitriptyline for managing her chronic pain. She was referred to orthopedic surgeon in the district hospital, who in turn recommended that she should go to Raipur to get her hip replaced, which is 350 kilometers away. And patient said that she can't go to Raipur. So that's the end. That's how the typical clinical interactions end. And we as clinicians feel that my responsibilities are over. I gave her a diagnosis, which she didn't get for 40 years, and that's it. So, this usual, what is happening largely is like what I call inside the skin approach to, or biomedical approach. So whatever is inside the skin of the patient, skin as a wrapper of the patient, we are happy dealing with that. The moment it comes to outside, what is happening in the real world and how the patient is placed inside that overall society, we shrug away from that because we think it's too complicated. So as I said, the effect of larger social, cultural, economic, political, and other structures, which are often ignored, or largely, as I said, we consider it difficult to address as clinicians. So the question is the care provided to her equitable? And I'm sure you're going to see this more and more again. So let's try and look at this picture. So this is a wonderful picture which shows the reality, where there's someone who has so many boxes who can stand on the top and see the match. And there's someone who is like in a pit, dugout, can't even can't even look at it. And then we moved, as Dr. Ritupriya mentioned, we moved to age of equality. So where we at least started giving something equal to everyone. And then we go to equity, where now we are more nuanced. Those who need more, we now want to give them more. And then ultimately it's liberation. So if someone asks me what are the recent advances in medicine, this is how the medicine should advance, right? We never talk about, we talk about a technical advance, but we don't talk about this advance where we need to move, further away. So again, Dr. Anand has actually, this is advances in medicine when we are discussing equity in medicine. And so, but then so if there's a patient who comes, how do I sort of, look at equity need of that patient? So what happens is when the care is inequitable, we need to understand their vulnerabilities. So what makes care inequitable is the patient has vulnerabilities. And as soon as I start thinking about those vulnerabilities, it starts taking me away from this inside the skin approach, and it makes me think about larger social picture. So equitable care is nothing but, in addition to addressing the medical needs, we start addressing the vulnerabilities in a more equitable manner. And this is another picture. We talk about equality, like, maybe we are on this top panel. And now we have to think about the panel where as we move on, as we advance in medicine, we need to give more individualized care which is suited to that person. So then how do I figure out what are the, how do I figure out that I'm going to make this care equitable? An answer to that is start expanding your social history. So, when we start asking about how they are surviving, so they, the husband says that they only can take one crop in a year because there is a canal that supplies water, and then it only supplies during Kharif season and not the Rabi season. Then rest of the time, husband works as a manual laborer with his 18-year-old son who has quit education because he doesn't like it. The way it is taught in the school, but they are, the patient is hopeful that the younger one is 8 years old and maybe he will study more and, get the, family out of poverty. It's very difficult to meet the ends meet, worried that she will not be able to help family in farming due to increasing pain and disability. So she's also a laborer. She's a contributing member. In addition to holding the house, she's also working in the farms and providing care. And now that could be jeopardized because of her avascular necrosis of hip. The government supplied ration is about 35 kilos per month per family, and their requirement is about more than 50 kilos. So they have to buy the rest of the rice, from the market. House, she has a Pakka house from Atal Awas Yojana, and it's important that, if you want to do social medicine, you need to know these government schemes that benefit patients. So again, that's a good, good thing there that she had some benefit from social protection scheme. But there is no public transport in Chhattisgarh. So they need to possess a vehicle, which puts extra cost on them. Education, the patient is only educated 5th grade, which makes that, she may not have access to the knowledge about this disease that she is going to suffer from. And she went to, we sent her to the disability board, and the board realized that she has AVN, which is treatable. So she cannot be given the disability benefits, because what if you got operated tomorrow and then you will not be disabled? And what's the disability benefits? She gets pension of 300 rupees per month. So there's medical doctor who's sitting there making all these judgments, saying that if you get better, then whatever certificate I have given you might be in problem. And it's interesting because we say that, since she's walking, she walks into the room without much of a pain, the person doesn't give her disability benefit, the doctor in the disability board. Now she's working with her hemoglobin in 7 to 9 range. And, since she has sickle cell disease SS, her hemoglobin is not going to go above 9. So, but it's not considered disability because she's walking around. It's not considered disability. So just giving more time to, listen to more expanded social history can help understand patients' disability more, because we have very fixed ideas about disability. Then the other thing that we often miss out is in mental health history. So she's bothered by constant pain during daily activities. The intensity is 5 to 6 hours on 10. She cannot sleep many days due to pain and worries. She feels sad. She's tearful. At times wonder why she's living, but she knows that she cannot, do something to her because she has to take care of the family. And now she's more worried because we told her that you have a condition which has surgery, but she's now worried, how do I go to Raipur, which is a far off place, and probably need lots of money to get the treatment. So what are, now let's again, so we talked about individual level vulnerabilities, but then we can also expand a little more. So from individual level vulnerabilities, we can talk about structural vulnerabilities, and I'll in short explain what structural vulnerabilities is. And in that structure, we can literally fit in the individual vulnerability. So what are the individual level vulnerabilities that we can think of based on the interaction that we have? I mean, if you get more detailed social history, you will identify 10 more individual vulnerabilities. So having sickle cell disease, she's going to have anemia. She's going to be working on a hemoglobin of 7.5 for rest of her life, which is she's not completely fit. AVN, additional disability. Gender, she's being a woman, she has to have, she has to take care of her house and also contribute to the economic activity. Economic hardships are there. Low on information, she didn't know about the disease, which sort of limits her, options to seek care, seek guidance significantly. So that's, lack of education is a significant challenge here as well. Now let's look at structural vulnerabilities. And structural vulnerabilities, the structure is defined by Oxford English Dictionary as an arrangement of organizations of interrelated elements in a material objects or system, or the object or system so organized. And in social science, they are defined as, it's the hierarchies through institutions, policies, economic systems, and cultural or normative belief systems such as caste, tribe, socioeconomic status, and gender. So let's try and zoom out and see, what structural vulnerabilities she's sort of operating in. And we sort of created a framework which we published in while dealing with deaths among one tribal community there. So one can look at various structures. So what is the biological structure? Biological structure, she's trapped in this body which has sickle cell anemia. She has pain crisis, she has AVN. But what are the interventions? So many times the social problems seem unsurmountable. So we need to remove that from our head, because even social structures can be addressed to some or more extent. So for the biological structure, we have hydroxyurea total hip replacement, which can take her to a better position than what she is right now. What are the environmental constraints? So she's from a farming community. She need to work in the farm, only one crop due to canal water. So can there be potential interventions? Yeah, I mean, if you get her total hip replacement, she might be able to contribute more to the farming activity and maybe more pain-free. And if you have to work on, just canal water, you have to reach out to a person who's in the government and see if you can do something regarding canal water, which is going to be a little tougher. You come to economic challenges. So poverty, she is barely managing. So what can we do as an intervention? We can provide her transportation support to go for the total hip replacement at Raipur and getting the surgery done under the Ayushman Bharat scheme. Older son did not study much, may stay in poverty. So again, the son not getting education is a hurdle. So we can, as doctors, we can advocate for economic benefits to patients with sickle cell disease. And we have been trying to do that in Chhattisgarh. Just as an example, in Telangana, they have a monthly benefit of 10,000 rupees for sickle cell anemia patients. So it's not that, it's completely out of consideration. Look for job for a son which pays higher. And this is something that you could do if you have social work support. So what are the social structures? She belongs to a certain caste, OBC, which puts her, a lot of constraints on her. So explore and use of all available social benefits for OBCs. Cultural factor, gender norms, certain work such as fetching water, sweeping house to be done by women, and son and husband can help. And actually her son and husband are helping there. There is something called as material structure. So lack of tap water, so patient has to carry water on her head. So one of the major limitations, she said, is now I cannot carry water on my head. The drinking water she needs to get. So see if tap water can be made available early in patient's household. What is the technical and knowledge structure that she operates in? She operates in, she usually seeks care at the public health system. And the public health system, doctors don't know how to treat sickle cell anemia. Nobody trained them. It's not that they're malicious. Nobody really told them how to, take proper care. This is despite hydroxyurea, which is an expensive drug, being available freely in the public health system. So there is something, we have good interventions that we can do there, where we build capacity of the providers, setting up SCA care ecosystem within the public health system, knowledge building for patients, advocacy to improve care of sickle cell disease at the state and national level are some potential solutions. Administrative issues, reluctance on the part of medical board to give 40% or more disability, just because she will get 300 rupees per month pension. So again, we have to do advocacy at the state and central government level to see whether they can, any sickle cell anemia SS patient can get a disability certificate. Legal issues, easing out these rules to declaring disability, and as I said, advocacy for changing these rules. Political structure. One of the challenges of sickle cell anemia patient had is they had no voice. Nobody heard of them until this central government scheme came in, and the state also got aligned. So state of Chhattisgarh has now keen interest in improving care for sickle cell disease. So that political alignment had to happen. But these patients are, largely from poor communities. None of the politicians seem to have sickle cell disease. So they are from communities. So if the politician has cancer, you will have large cancer institute coming up in the state or in the district. But it seems that nobody has their relatives who have sickle cell anemia. So creating local and vocal sickle cell associations, facilitating patient-politician or patient-policymaker interactions, because of the power structures, they cannot go and talk to the health secretary. They wouldn't get that chance. So these are potential interventions, and some of them might sound difficult, but I'll come to it and see, what we had done about it, and I'll share our learnings. So the question that we had is, can equitable care for sickle cell disease be provided in the public health system? So one thing is sickle cell anemia, which is a genetic disease. As against an infection, this genetic disease is going to be a lot tougher to treat or address. And the second tough part is the public health system. So if you're working in an NGO, you have a lot of control on your NGO. But if you're working with the public health system, you don't have any sort of control. So we took these difficult things and we tried to sort of, see if we can solve this puzzle. So why sickle cell disease? 10% of the population in Chhattisgarh has sickle cell gene. So every 10th person that you meet will have sickle cell gene. It's a huge public health problem. And 0.1 to 0.5% of the population will have sickle cell anemia. So the state doesn't have clear estimate, but it could have anywhere close to 1 lakh patients with sickle cell disease if we go by these population-based studies. So what we did is we took up this challenge and we started working in two districts, district hospitals, one in Ambikapur and Sarguja. You can see a map of India, map of Chhattisgarh, and the blue parts where two arrows are there, that's where we operate. And that's where the two district hospitals are situated. So why Sarguja? Close to 50% of the population is Adivasi in this region. 85% of the population is rural, and secondary level care was almost non-existent. So there's a medical college that has come up for a population of 5 million. Otherwise, they had to go 350 kilometers south to Raipur. If you want to give a state's benefit, then northern you can go to Varanasi or Ranchi. So then again, so what are the barriers? So in order to solve a problem, you need to systematically understand what are the barriers. So what were the barriers? So lack of clarity regarding screening and diagnosis of sickle cell anemia. Most of the doctors did not know how you screen for sickle cell disease, or if the screening is positive, what is the confirmatory test? Is it easily available? Confirmatory test itself was not easily available. So few years ago, state did massive screening, but there was no treatment and there was no confirmatory test. So close to 1 lakh people were screened and no confirmation of diagnosis. Physicians were not confident of using hydroxyurea. Someone scared them that hydroxyurea is used in cancer, so you cannot use it. So they were very scared. But then how were they treating? They were treating sickle cell anemia as thalassemia. So every time patient comes with any crisis, just give blood, patient gets better, discharge home. And these hospitals had become blood pumps. I call it blood pump. Just like petrol pump, you go there, you fill in the gas and you move on. So patients would come, get admitted. They don't even wait for discharge card. They just go home as soon as blood transfusion is done. And there's no mechanism to track these patients. There's no mechanism to ensure regular follow-up. There's no pneumococcal vaccination that needs to be given to them. There's no penicillin prophylaxis. So these are known tools that we have which can reduce suffering significantly, but they are not being used. So what we did is we came out with key interventions at the two district hospitals. First and foremost, we posted 3 care coordinators at the district hospital. So their job is to, within that large public health ecosystem, coordinate care for the patient. We worked to make sure that necessary diagnostics and medicines supplies were available. We created simple training material. So we had to demystify care of sickle cell disease, and we created simple 2 A4 size pages guidelines, which any MBBS doctor, and for that matter, even a nurse practitioner can see and treat patients with sickle cell disease very safely with hydroxyurea. And we created patient education material in simple languages. We created upward and downward linkages from district hospital to CSC to HWC and then higher up to AIMS. And the last part, and not the least, was creating communities of practitioners and patients, right? So these are the interventions that we tried to do, and let's see how they work. And in order to do that, we had to design certain key strategies. The key strategies that we used is a combination of biomedical approach, social medicine approach, and public health approach. So let's see what each of them sort of entail. So biomedical approach ensures appropriate disease diagnosis. So you need to have technical knowledge as to how you diagnose a patient with sickle cell disease, and treatment of complications, so as to provide optimal medical care. Then within the public health system, you need a public health approach. So public health approach, it's a project management approach. It's sort of sometimes it's dehumanizing, but simply is, you provide leadership governance, you provide service delivery, you ensure financing, workforce is there, you ensure products are there, technologies are there, vaccines are there, and health information system, and you do policy engagement to improve things. And both these things without the larger guidance of social medicine. So what social medicine does is it provides larger direction. So for me, these are two engines. So biomedical approach and public health are engines, and the guidance or the steering wheel is this social medicine approach. And what does social medicine approach? You use empathy, you use understanding of vulnerability, you use lens of equity, you do structural assessment, you do community empowerment and social justice. So if you take all these three, then you can, the chances of success increases. So what, again, as I said, key strategies, we're using care coordinators who are not doctors. As a doctor, sometimes we are too busy just managing one by one patient, and rest of the care in chronic diseases, I would say, 60 to 70% of care is actually social care, and 30 to 40% is just proper medical care. And then we did handholding and training of providers. So not only just training them, because in government health system, they're all training PDs. They're all victims of training. Excessive trainings happen and they cannot retain anything. So we have to sit with them, we have to guide them. We demystified care, and instead of focusing on specialists, we created multiple primary care providers who can provide reasonable primary and secondary care for sickle cell disease. Additionally, we had home visits and strengthened the demand side by community engagement and empowerment.
So this is our team of district level coordinators. They have a list, they create a registry of patients where they have all the details. So in case you need to reach out to a patient, you can, go and reach out. And I'll not go into their detailed roles, but they identify vulnerable patients. And again, as I said, for equity, you need to understand vulnerabilities. So you have women, children, Adivasi people, poor patients, and this is a list of vulnerabilities. And they make home visits. Home visits are very important. All those who are interested in social medicine need to make home visits because you understand what is the context of the patient much better by home visits. And this is training. Then we have handholding, and we created these simple tools. And again, as I said, this you can see on the right side, those simple tools are now accepted by the Chhattisgarh government on their stationery. So that would be now disseminated to the entire state. We created patient support groups where patients are telling for the first time someone is interested in them, telling them how to navigate this disease and the condition. And then we had a large sickle cell conference, people self conference. So where 250 patients and their relatives came, and Dr. Yogesh Jain moderated it, and we had one-to-one contact with health minister, and they told, patient told their stories and challenges to the health minister directly. So what are the outcomes? So over the time, we enrolled, close to 800 patients over just 1 year's time period. And we can see that with this intervention, the screening efforts went up in District Hospital Ambikapur, and it slightly went up in District Hospital Surajpur because at baseline they had good screening system. And we ensured that when we are enrolling patients, we are specifically looking for female patients because otherwise, this can be missed. And you can see the percentage of, women patients were significantly increased in Ambikapur with this thing in mind. And you can see gender equity mostly equal. In Surajpur, slightly more males, but otherwise quite equal. Then age equity is also there. I mean, sickle cell disease has to be diagnosed as early as possible so that you can start treatment, not when the patient is 40 years old. So you can see we also monitor this age equity. The big question is, are Adivasi patients coming to the health facilities? So when we started this project, we said that at least 25% of all your patients should be Adivasi. The entire population, 50% is Adivasi, but you can see that at least there is reasonable representation here, and we need to improve more. And these are percentage of care patients who were for the first time started on hydroxyurea. So close to 70% of the patients were started for the first time on hydroxyurea. And you can see the monthly, hydroxyurea dispense as a crude indicator of how, at least the medical care part is progressing. So in District Hospital Ambikapur, 1,800 capsules were dispensed every month, and now that has gone to 15,000. And what does this lead to? So you can see that the percentage of enrolled patients who are getting hospitalized is gradually coming down. It's too early to call in 1 year's period. It takes 2 to 5 years for all these things to come down, but the direction is quite heartening. And you can see the number of blood transfusions are also going down. So family testimonials. So, the mothers now, patients and their family members are noticing that, pain is reduced. Now they're forgetting pain. Their blood transfusions have gone down. And this is, something that a patient's mother said after this conference that we organized, that there was nobody, they didn't know much about the disease and were lost and frustrated in the system. And for the first time, we feel supported. So what are the key learnings? So, based on this, reasonably equitable care for sickle cell disease can be provided within the public health system. Vulnerabilities, individual and structural level, need to be understood, and you can address them. Many times there is this inhibition that as a doctor, I cannot address it, but slightly come out of that doctor's room and start thinking bigger and start reaching out to people, and you can solve some of these. Providers need to be sensitized to the issue of equity. Nobody teaches us in medical college how we should have the lens of equity. And this is last slide. So non-doctor care coordinators are very important. So many times, the healthcare is very highly focused on doctors, but this team of care coordinators have done wonders in 1 year. And equitable care is not cheap because you're going beyond equality. So it will need additional human resource and additional costs. And communitization of care and building patients' voices are important to make care equitable. And voices of the most marginalized need to be heard and acted upon. So with that, I'll stop. And this is a large team effort. It's not run by a single person. So I'd like to thank all of them, and I'll stop.
Thank you very much, Dr. Yogeshwar, for that excellent talk. We have time for 2 questions.
So we haven't really have those many investigations yet. I'm sure there will be there. I mean, clinically, I have not seen it much, so it could be hiding. And we are now working to do some, provide some extra funds for patients to get advanced investigations done. But, that's a challenge. Dr.
Yeah, that's it. Thank you.
Thank you, sir, for the presentation. So you were emphasizing on social medicine, the importance of it. So I was wondering, what is the role of human rights framework within the interventions you had at what level, like micro level, doctor-patient relationship, or at the meso level, or at the macro policy level?
Yeah.
What is the role of it? And can you give some concrete measures within this that aligns with human rights framework? And the other question related to that I have is, how do the Adivasis, the tribal population in your area, perceive the idea of human rights? Because I believe the idea of rights is very closely related to justice, equity, and all that. So what is their perception about human rights?
Right. So very important questions. And again, as I said, when it comes to human rights, it's a large issue. And Dr. Yogesh Jain has been very closely working on at least rights for health. Human rights becomes too big a thing to sort of achieve or, address upon. But you can start with simple right issues like right to education. We started. So now right to health is the next step that Dr. Yogesh Jain is working on. So these are steps that you have to gradually take so that you go to the larger picture. If you start with, rights, human rights, then you will be shut down. You can't do much, right? So, but that's very important angle that we need to keep in mind, right? And the progress would be incremental. Secondly, coming to your, and again, as I said, these things need to be taught in medical college. I learned it on the go, and I can't claim that I'm the expert in it. But these are the things where we need to sensitize, so there needs to be a separate social medicine teaching in community medicine, and not the way that we are taught at this time. So that social medicine is a very different, the books that we have are very different and inadequate. So that needs to be taught. And coming to Adivasi people's perception, so they feel very vulnerable, so they had very equitable societies to begin with. And now they have to deal with the toxicity of non-Adivasi people who are extremely inequitable. So they see that, dialogue as very ideal and, very far shot. But again, as I said, we have to go stepwise and do things.
Dr. Yogeshwar, last question. Now that people get aware that they have sickle cell anemia, especially the homozygous, is there any social stigma attached to being aware of that?
That's a very interesting question. So at least in our region, we didn't see that. It only comes up when, at the time of marriage in a big way. And that is something is a very delicate issue. So we now are reaching out to certain communities where this issue is very common. So right now, the way we think that we can solve this is by doing mass screening, give people cards, and then they will show the cards to each other and not marry among themselves, and then this problem will be solved. It's a very naive way of thinking of it. It's a very delicate social issue. So we are now trying to reach out to certain communities which are disproportionately affected by this. And it's going to be a long walk. I mean, in the sense that we are just reaching out to them. They have to discuss within themselves because there will be discrimination. Whosoever is well-intentioned person, will have trouble accepting someone with sickle cell disease as spouse. But that has to be done, and it has to be done beyond the realm of biomedicine, for sure.
Thank you very much for your talk, and thank you for the work that you're doing.
Yeah, thank you.
Thank you, sir, for that talk. I request you to kindly present the memento to Dr. Yogeshwar.